Welcome to our In Conversation for March. It's wonderful to have you join us today, and I'm really looking forward to this conversation. We are also joined today by Auslan interpreters Tanya and Kerry, who will take turns to translate while we're going, and you can also access the captions, closed captioning down the bottom of your screen. I will start by welcoming you all and acknowledging that I'm coming from Wurundjeri land, which is part of the Kulin Nation in Melbourne, Naarm, and I would like to pay respects to elders past and present and just acknowledge the generosity of spirit and strength of our Aboriginal brothers and sisters and Torres Strait Islander brothers and sisters, and recognise that they have loved and nurtured this land that I live on and work from for many hundreds of thousands of generations. I would also like to acknowledge the lived and living expertise of all victims and survivors of child sexual abuse. I'm harnessing all ages, cultures and abilities, backgrounds, and commit to substantially addressing the harm of child sexual abuse now and well into the future. And we particularly recognise children and young people who have disabilities, who have also experienced child sexual abuse and live with that history. And thank you for joining us and committing yourself to being part of the solution and part of the change. It's wonderful to have you. I would like to also acknowledge that in the last year we have lost, in the last month we have lost the board chair of the National Centre, Dr. Joe Tucci, who passed away a couple of weeks ago, and he is and was the original inaugural chair of the National Centre and was the CEO of the Australian Childhood Foundation. The National Centre is a partnership between those three organisations, Blue Knot, the Healing Foundation and the Australian Childhood Foundation. And we're 2 years in to standing up a national centre that responds to the experience of child sexual abuse, and central to this work is elevating the voices of victims and survivors of all ages and life stages and communities. Thanks, Lee. We would encourage you to note these numbers, and if you need to access support structures either through the course of the webinar or afterwards as you're considering what you've heard, because these are challenging conversations to have, and we want you to reach out for support as you need. Thank you. All right, well, let me introduce to you the most exciting panel. This is a webinar that brings together lived experience with insights from research and practice experts to explore and understand the structural inequalities that exist that make people with a disability more vulnerable to abuse, and the contributing factors that compound trauma in terms of people being believed and then able to access and receive the support and the safety that they need. We're really delighted to have three important leaders in this space to have a conversation with us today, starting with India Bryce. India is a forensic social worker and senior lecturer at the School of Psychology and Wellbeing at the University of Southern Queensland. India's research focus is on child sexual abuse, cumulative harm, and trauma-informed pedagogy. India has published books, book chapters, and journal articles from her research, including 2 co-edited reference books on child abuse and neglect and child sexual abuse, forensic issues in evidence, impact, and management. Welcome, India. It's wonderful to have you. Victoria, I'll come to you in a sec. Well, I'll introduce the others. Victoria Reid is a senior trauma counsellor at WILD, WWILD, Sexual Violence Prevention Association. Her lived experience of child sexual abuse and domestic and family violence underpins her practice when supporting victims and survivors and their families and communities. Victoria is a passionate advocate for people living with intellectual disability who experience complex intersectional vulnerabilities and system failures. It's an honour to have you, Victoria. And lastly, Chelsea Troutman, who's the Clinical Director and Advanced Forensic Specialist Practitioner at Elements ABC, Assessment Behaviour Consulting. Chelsea has held roles as Victoria's Practice Lead for Compulsory Treatment Legislation, as well as a Practice Lead for Young People with Disability in Victorian Out-of-Home Care System. So for those who are joining us, welcome to an extraordinary panel. And thank you to the three who have joined us today. You are welcome to send in Q&A through the Q&A function, and we'll try to incorporate that into our discussion. We really value your questions so that we can make it useful for you. But where I'm going to start is asking each of them, and I'll start with India. What do you know? What do we already know about child sexual abuse and disability and the interface?
So from my background, which is both in practice and within academia and doing research in this space, there's a couple of things we already know, and there's other people on the panel who'll speak more in depth to the stats, but we do know that and there's a bit of a lack of information around the exact statistics because that information is quite hard to gather. But we do know that 7.3% of all victims, that the 7.3% of all victims are those with a disability who experience child sexual abuse, and that they're 4 to 10 times more likely to experience sexual abuse than the general population. And I guess from my background, the biggest thing that we know is that there is a relationship between disability and risk and disability and trauma. And I'll definitely speak more on that today throughout the panel around why that's important.
India, thank you. Chelsea, if I ask you the same, what do we know and what do you know already about child sexual abuse and disability?
Similar to what India was saying, we know that children with a disability, persons with a disability, are at higher risk of experiencing maltreatment and different forms of violence, including sexual violence. I think what's really important to understand with this population is actually the contextual factors that surround their experiences in their life. You think about the NDIS, and you have a lot of young people who are requiring one-on-one assistance from people who are somewhat strangers to them in terms of their life. They're not always supervised. You have communication breakdowns or increased vulnerabilities that are going to increase the risk of not only abuse or harm, but it's also going to increase the risk of not being able to speak up, not being listened to, not having the pathways to actually communicate effectively by nature of deficits in those skills. So I think the barriers these young people experience by nature of their life and the circumstances surrounding their life experiences, even social isolation, particularly in, say, a school setting or in an institutional setting that requires specialist intervention, all of that plays into the impact of sexual abuse, and it plays into the impact of victimization for this group.
So it's almost like a exponential factor, like kind of creates additional layers of complexity.
And then at the same time, it creates layers of complexity, but it also creates avenues for more advocacy or avenues for people to hold responsibility and recognize that we actually all have a responsibility across every point of contact for these young people, knowing how vulnerable they are. So this is why I'm so passionate today, just to make sure that everyone in the community recognizes how vulnerable this group is. And we all have a responsibility to pay attention to this group and pay attention to the settings they're interfacing with, their own vulnerabilities, and not being able to communicate effectively, not having just the basic right to be able to communicate and not provided that. So, yeah.
Chelsea, I'm going to come back to you in a moment. I do want to go to Victoria, but I'll come back to you in a moment to just ask about, advice to workers around how to pay attention, what to look for and how to pay attention to those vulnerabilities. Victoria, welcome. Thank you for joining us. And we did have some technical problems, so we're very pleased that Victoria's here with us. You'll have to come off mute, but I'd love you to kind of comment on that first question, which is what do we already know from your point of view? What do we already know about disability and child sexual abuse?
I mean, we're just coming off the back of the Disability Royal Commission, obviously, which has had a look at experiences of violence, abuse and exploitation for people living with disability. And that's very much sort of re-highlighted what everyone's saying here is that there is just a disproportionate percentage of people living across the lifespans, children and adults, who experience multiple forms of violence, including sexual abuse as children. The Royal Commission that we had into institutionalised sexual abuse put those numbers at 14% of children in institution. So, you know, between the 7% that India highlighted in terms of probably more general population, right up to those who probably because of disability are then, you know, twice as much. So there's just a massive disproportion between, you know, these two figures that we're looking at. And they did identify that of all children that experience trauma and abuse, not specific to sexual abuse, 50% of those will have a disability.
That's a much higher than I think we probably all understood to be the situation. So Chelsea, can I come back to you? What should we be looking for? So we know that our audience here is both practitioners, people living with their own experience of child sexual abuse, community members and family members, and researchers. So we do get this fantastic spread of expertise in the audience. But coming back to you, what would you be encouraging people to do to pay attention to the issues of child sexual abuse?
I would say the first step is almost stepping back and saying education across every sector. So if we think about education in school settings, education with GPs, education, particularly in the NDIS, you know, if we think about respite facilities, support workers, transportation, so public transportation or, you know, just getting to and from school sometimes is done by strangers who don't know the young people. So I would say the first step is actually education and recognizing that this population is at higher risk for various forms of maltreatment and harm, but particularly sexual violence. So I think if we all have that general understanding that they're at higher risk, then really our first step is recognizing everyone's role in educating and providing protective skills to these young people at a really, really early age. You know, I think about kinders and preschools and childcare centers. It is so pivotal that from a very, very early age, we're actually recognizing they are at increased risk, and we need to be explicit in our instruction and actually teaching these young kids around their rights. You know, we think about children's rights, and we think about then children with a disability who may not fully understand actually their rights. I mean, like I said, with communication, the fundamental right to being able to communicate and being heard and being believed is already compromised with children in general, particularly with trauma, but add the layer of not being able to communicate so people can hear you is extremely difficult. So I'd say the first step is actually education, and it's everyone's responsibility to actually promote protective skills with these young kids at a really, really early age. Teaching them rights and their own rights and how to communicate effectively. And then the second part, so I could keep going, but the second part is, as a behavior practitioner, it is absolutely our responsibility to not see behavior at face value. So what's really difficult with this group is that a lot of kids will access support in relation to behaviors of concern. And if we purely just look at the behavior in that immediate environment, then we're neglecting what's happening underneath. We're neglecting their whole story and their whole experience across different situations and settings. So I think it's really important to recognize behavior can occur in terms of various forms of overt behavior. We see externalizing behaviors. You might see emotional behaviors. You might see changes in their behavior, such as regression in skills, regression in developmental milestones. I would say getting to know the person and actually recognizing change is really, really important. And then finding avenues to support communication, but also ensuring that child knows this is a safe person and recognizes what safe people are. Half the time, these young people are so reliant on support workers, we're almost assuming they just have to trust these people, right?
Yeah.
And these children are entrusting adults to say, right, you've put this person in my world to help me. They might require physical assistance, a whole range of assistance, particularly if there's comorbid disabilities. And I think it's really important that we teach our kids how to recognize safe people and who to go to, given that they're interfacing a whole range of people.
Yeah. Thank you, Chelsea. I'll go to India. and ask a bit more about that, because your research is around trauma and recognising trauma too. And so how do you tease out what's disability, what's trauma, what and does that matter? And how do you respond to that?
And I think there's two answers to that. One is that, you know, partially this is about understanding, and I take Chelsea's point around children's rights, but also a child who's experiencing a disability, or even an adult experiencing a disability, has the right to be aware of their own vulnerability as well. So making sure their care team, obviously that depends on capacity and what their disability is, but doing as much as we can to empower them around addressing those vulnerabilities and increasing their ability to self-protect if that's within their capacity. And also building on that to work with their care team and with the system around them to increase their knowledge of vulnerability and risk. And so we, you know, in terms of teasing out the link between trauma and risk to some, or trauma and disability, there's a bit of a cyclical relationship that happens there, where you might have disability, which then increases vulnerability to abuse, in particular child sexual abuse, but can be broader than that, obviously. And then we then need to be dealing with that, and then the trauma that might come from the child sexual abuse or the abuse they've experienced. Or you have, you know, the reverse of that, where you have trauma and you have abuse that can cause disability and then still increases risk and more trauma. So it entirely depends on that story that Chelsea was talking about. So in some cases, it doesn't matter. It's about acknowledging the relationship more broadly between trauma, risk, and disability, and that all those things work together all the time, and that we need to be addressing them all together. That the story Chelsea talked about, that's part of that narrative, that they have a trauma narrative, they have a vulnerability narrative, they have a disability narrative, and they have a life narrative, and those things all fit together. And if we acknowledge it as a whole picture, we can address them all together. And I know that we'll talk about this as the panel moves on, but we have a systemic issue around acknowledging trauma and disability together, and therefore acknowledging risk as part of that. So I think we have some work to do.
Thank you, India. And yes, I think that's right. I think that's an understatement. Victoria, is there advice that you can provide, particularly around young people, children, young people who have intellectual disability, given that's your area that you work in, around this link between this educational piece, I suppose, about teaching children and young people about who's safe and what their rights are and those sorts of issues? Have you got advice for us around that piece of Chelsea's advice?
Everything that my other panelists have said is exactly right. It's about educating, I think, starting with the systems who are involved in young people's lives, to recognise that if you're working in a disability space, you're likely going to come across high levels of trauma. So being aware of that, and then things like early education in schools, in kindergartens, for parents. You know, young people with intellectual disability certainly have the capacity to learn. It's about making the information accessible, but having it embedded in programs so that it's a necessary part, not an option. You know, currently in the curriculum, it's included in the curriculum, but it's certainly not taught across the year levels. It's called upon particularly when schools think it's relevant around certain ages. But that education for young people is key for then helping them to, you know, overcome other barriers that they might have as children or children with disability, in terms of, you know, later making sense of things, disclosure, seeking help, all those sorts of things.
Yeah.
And the work itself it's easily done if you've got the right materials and you've got the right people to connect with the young people.
So I'm going to say, talking about children for the minute, but we do have a question about people living in with an experience of child sexual abuse and needing support in remote and regional communities as adults, and I'll come back to that. But Chelsea, can I come back to you around, you know, given that we know these are the things that we need to do, education, know everybody's role, look at the sort of circumstances of what someone's presenting with and the impact in their lives of what's been happening. Are we doing it? Is it actually happening? And what's getting in the way?
If I think about the NDIS for the moment, we have this opportunity right now where these children, these adults who have never received supports, and the level of supports have access to this now, or they should, by nature of the idea of the scheme, they should. And so I would say we have an opportunity at the moment. The door is open. We have an opportunity. I don't know if there is enough knowledge out there, there's enough training. I don't know if there's enough compulsory expectation in terms of this. And I think that's where we're at now, is it is compulsory. And I think it's about really going back to even acknowledging or speaking with parents and recognizing, how do you actually interview people that have contact with your child? How do we actually make this at the forefront of our minds at all times? I don't think it is happening yet. I think there's still, even in terms of behaviors, I think there's a lot of masking. I think there's diagnostic masking as well. And I think so what happens is you have an issue where someone gets diagnosed with a behavior disorder, a whole range of presentations that neglect what's actually happening in terms of personal need and their story. I think you're getting this real superficial view of things, and that can actually lead a child down a completely different path and neglects their story. It's essentially validating, I don't believe you, or reinforcing, I don't believe you, and reinforcing just a loss of grounding of who they are. And so I think that that fractured approach is extremely detrimental. And I think that's probably where we're going wrong, is that there isn't enough training and knowledge from the broader sector who have the most contact with this population. I don't think they're trained enough. And I think it should be absolutely compulsory that that's the foundation. It's trauma assumed practice, really, at this point. You should always assume the element of trauma, and you should always start there and understand the widespread impact of trauma presents across psychological, social, emotional, physical health. And we actually need a holistic approach when we're assessing or we're engaging in behavior support.
Thanks, Chelsea. India, why don't we understand and bring trauma together? What's happening in relation to trauma from your perspective with this cohort? And you're on mute.
This is why I never turn the mute on, because I never turn it off again. I think that's a really tricky question, in that I think given that so many other sectors are becoming very trauma aware at the very least, and that there's been almost an overdoing it in some cases, where it's become a bit of a buzzword, or, this sort of thing, which can often lead to it not being particularly meaningful. But I think it's being done really well and fully in other sectors. It's really interesting that we're siloing, and I hate that word because it's overused, but it is a good example of what's happening in this sector. Is it's disability, and it might be differentiating between a psychosocial model versus a medical model that underpins our disability sector. But I think we have this, well, that's a disability, and I know that in my practice I've had great difficulty whenever I've put forward any kind of advocacy for one of our clients with a disability who's on the NDIS or NDIA scheme, and mentioned the T word, and I get this huge pushback, to the point where I've even had clients, oh no, we're not going to fund that, because that's not a disability service. That's not something that can be dealt with through this funding. And I know when I first started coming up against that, I was quite horrified, because we're becoming so much more aware in other sectors. We seem to be becoming more siloed in this one, and I have no idea where that comes from, other than to proffer that it might be from the background of that medical model. But it does so much damage, because if we're not understanding the way trauma and disability work together, whether it be to increase or manage risk, or whether it be in outcomes and in terms of how we can get better outcomes for our clients, then we won't do as well as we could with the clients that we're serving. And it really does create a massive chasm in the lifespan outcomes that clients with a disability can have, especially if we're talking about what Chelsea mentioned before around early intervention. If we don't start linking the two in that early intervention, we're missing things, especially when we know that there's often some crossover between trauma symptoms and certain disabilities. We know that some disabilities, such as various neurodiversity related, so ASD, ADHD, some of those things can, when you talk about children with presentations, the presentations can be incredibly similar. So by piecing the two together, we're not missing anything. You know, it's about being as holistic and as comprehensive in our interventions as we can be to get the best outcomes. So I don't know where it comes from that we've created this massive discord between the two, and that we're actually, you know, particularly around disability, there's almost a visceral reaction when you mention trauma. And I don't know where that comes from, but I know that we need to fix it.
Thanks, India. I think we do. What do you think, Victoria? Where does it come from your point of view and your experience?
I think a lot of it is, it's still around the fact that, you know, unless you really work in this space, particularly as a practitioner or a researcher, a lot of people still walk through with the blinkers on that child abuse doesn't happen, in particular sexual abuse of children. And then you add on to the top of that people with disability being abused. So the people who can make the big changes that we need in terms of education and supports and big systems like NDIS they're just not recognizing it. It's in the too hard basket still. And so it's been done well for those people that can access the services where they are. But again, that bigger approach, which early intervention, which of course leads to prevention rather than tertiary, it's just being missed. It needs to be a whole of society, you know, sort of shift in just saying, yes, this is a reality. We need to do something.
We need to own that. So I'm going to come back and ask you about the kind of perceptions that community has around disability, and wondering if that might be part of our problem. But Chelsea, coming to you, do you know, given you've spoken a bit about the NDIS, do carers get training in body, you know, and training in how to address sort of, you know, some of the challenges in body safety, consent, etc., etc.?
I can't speak across the board. There's a zero tolerance for abuse that the NDS, the National Disability Service, has actually put forward. And I think that's a really powerful statement. So it's essentially, we have no appetite for this, for abuse. That's a really important step. And so you would assume the funnel would mean that everyone would be monitoring, provided training to monitor signs and symptoms of control, coercion, and different forms of abuse. Again, this speaks to there's a lot of attitudes and biases, and there's a lot of settings that I think we have to cover. And it's our approach in the matter. So, for example, if a child presents with difficult behaviors or what's categorized as behaviors of concern, a lot of times there's an avenue to explore medication, which would be categorized as chemical restraint. And then you might get a behavior support plan that, you know, actually manages behavior in that specific context. The issue is that's not necessarily about the cares at that point. That's about the GP providing a response to a single issue, and it's about someone else providing a response to a single issue. So I'd say I don't know across the board if there's compulsory training. I think it's becoming much more relevant. There is, under the commission, there is a lot more information around trauma, and I think it's spoken a lot more about it. There's a lot more movement within the area of applied behavior analysis, given that sits under positive behavior support. There's a lot more focus on actually understanding trauma and the trauma of the impact of trauma on behavior presentations. But again, I think it's across all the different settings that people need to be really well understood and actually need to be advocating.
Settings as well. That's as right. The specialist settings,
yeah.
And that would include, I'm guessing, education and medical and
primary health.
Yeah, which has come up in the chat. India, I'll come to you. You know, are there, you know, back when you spoke before about the medical model and the kind of sense of there being silos in thinking, that's certainly something that's come up in the chat about that. You know, how do you propose we combat that as a community? Because isn't it about, I'll extend the question, I'm not making a speech, but I'll just extend the question, just to link you said, you know, life narratives, disability narratives, trauma narratives, risk narratives are really about a whole person. what we have with some of these disability services, maybe as an unintended result of the NDIS, is this kind of compartmentalising of those things and somehow ending up with priorities around particular presentations or particular behaviours, as Chelsea says. So what do you think of the challenge? You know, what do you think we need to be doing to challenge those kind of really simplistic descriptions of people? You're on mute, sorry.
Okay, I'm not turning it off again. That's it.
No, good.
I tried twice, didn't work. It's interesting that we're having this conversation in this space because as a social worker and as you mentioned in my intro, I'm sort of heavy in that forensic social work space, which is where all these different systems kind of come together. And in that space, we always talk about intersectionality. We talk about how a whole person, I mean, even in education, which was my job long before that, we talked about the whole child. You know, there's been this dialogue around understanding that people are not just their trauma or just their disability or just their, you know, their upbringing or just their careers or, you know, whichever way you want to look at it, or just their gender, just their race. Yeah, we can go on. This idea of intersectionality has always been embedded in social work and quite heavily in where I typically sit, which is over in the child protection space or, you know, that sort of area. It's interesting that it seems like we've actually gone backwards in creating these silos and creating this understanding of the person is their disability. And I wonder if to some extent it comes from our funding models where we've always had to, and I certainly saw it when I was in education, that as a teacher and as a guidance counsellor, the best way to access support and funding is to highlight the person's disability or need and to whack that label on them, and they become the label, and the label is powerful in and of itself because it attracts the help. So you actually had to make that child all about, or that person all about their disability in order to actually get the help that was necessary. And I suppose the disability space is not dissimilar, and maybe we haven't moved past that need that we make such a big deal about, and the documents and the evidence and things we need to put forward to access those kind of services are so focused on that disability that the person does become the disability and has to in order to advocate for that help. So I wonder if to some extent that overarching approach is actually informing seeing that person and seeing that child or seeing that adult as their disability for the, you know, because we're focused on the connection between that label and how we help them. So in terms of shifting that, I think it's about looking at models that have made that shift to looking at the intersectionality between and adding those things, adding gender. I mean, even when you look at disability, if you look at the link between sexual abuse risk, disability as how it exacerbates that risk, gender and age and those kind of factors then play into that as well. So if you don't just look at the way, you know, disability affects risk, but the way you look at all those factors affect risk and experience, that's going to be a much better way of addressing that person's needs, I think. So advocating for that shift to the whole person, I think
yes, and keeping an eye on the person in the centre of all of those kind of frameworks. And that comes back to your point, Chelsea, about all the circumstances around someone's and how they're presenting. So we've talked a bit about kind of laying the groundwork for training, for keeping, you know, for paying attention, for understanding vulnerability and increased risk, and what you might do educationally to support people. Then we come to the question of how we might know there's a problem, and how we might understand there to be a problem, or that a child is needing to or wanting to make a disclosure. And then we will come to, well, and then how do we respond? So Victoria, what are your thoughts around the challenges in understanding if something's happened to a child or a young person who has this history?
I think, like Chelsea said before, there's quite often with young people with disability a focus that the challenging behaviours or behaviours themselves are innate to the disability. So there's just no consideration of anything outside that. But it's been really important to remember that, particularly when there is any deficits in communication, that behaviour itself is that communication. So it's really looking for changes in that behaviour, regression, like Chelsea mentioned, somatic symptoms, getting ill more often, toileting might change. And it really is, again, it's about looking at the whole of that child and picking up on things that are changing. They're not always really dramatic. Sometimes they are, because it's, sexual abuse trauma is really, very interpersonal and significant type of trauma. But other times it might just be that they're a little bit more hesitant to go to school. They're, not wanting to catch the bus that they always used to like to catch. So it's really about being aware of that child. And ideally, it would be that all of the supports and systems that are working to support that child would have collaboration in sharing those concerns.
Yeah. And Chelsea, is it hard to convince people that there might be a problem, for a child that might involve child sexual abuse?
I don't know if it's necessarily difficult to convince. I think what's difficult is there's this paralysis. People get quite paralyzed by this. And I think they don't necessarily know what to do. And that fear almost creates their own avoidance. You almost have to coach them through and say, just like for the young person or for anyone, it's a process. Just going through the process of disclosure and going through recognizing what's actually happened in that it is actual trauma. That is a process. It's not going to happen overnight. And I think that's part of the issue, is actually getting people on board to recognize the symptoms, pay attention to those signs and symptoms, and then have a conversation that actually queries, could this be more? I think in a really safe way, because you want to hold the safety of everyone in that care team as well. So I think that's a really important thing, is that you don't want to run the risk of having silos or fractures within the care team that's surrounding the person as well, because it can be a really stressful thing. So I don't think it's about convincing. I think it is about people knowing, step one, what can I do? Because this is an overwhelming feeling, a protective feeling. And I would say paying attention to changes in behavior, regression in skills, but avoidance, exactly what Victoria is saying, avoidance of certain settings or people, that avoidance is a really, really powerful one. And there's a lot of, for young people, we're talking about assent here. And for kids who aren't able to communicate and say, I don't want to go there, we need to actually change our approach and say, I believe you. I recognize what you're feeling right now is real, and we need to stop there. And I think that's a really, really important first step, is recognizing the power in their ability to assent and say no. And that avoidance, I think, is probably one of the most pronounced presentations you'll probably start seeing, that I would like people to pay attention to a bit more, really.
Yeah. It's an alert, I guess. And it sounds from both of you like that's about the context of the relationship and what you know about this person, which takes us back to India, which is about the whole person and the intersectionality. So it is about the relationship that you build. And maybe one of the challenges is, as you said right at the beginning, sometimes these children, young people, are seeing different workers, different carers, different transporters, and there is an assumption that you have to trust adults, right? That adults are there to help us. And that's not clearly always the case.
And that speaks to that vulnerability. We know that in a number of settings where you have vulnerable people, you will often attract perpetrators. And so part of understanding risk is about understanding how those things feed in. And unfortunately, with disability, there is an increase in that, where you have, the criminology theory looks at how offending occurs, and they look at a motivated offender. They look at a lack of capable guardian or supervision, which is often common, especially in residential disability settings. And you then have access to a suitable victim. So you look at these kind of elements that are just, general elements for victimization, and you apply that to a setting where you have increased vulnerability, and those things are all exacerbated. And I think the relationship is really important. I think understanding the person's baseline, you can't actually find those changes and those shifts unless you know them well enough to know where they started. But also maybe taking it back even further to look at those risk factors and go, okay, well, what, even in the environment, what is a risk factor? So we're looking at age, and have a practitioner who's already in there, who's in, and I loved that trauma assumption, but also risk assumption. To go, it's not going to be the same for everybody, but we understand that this population has a set collection of risk factors that makes them extremely vulnerable. So if I enter with that, there are also things I can be looking for. Things like age, things like gender, things like type of disability. We know that intellectual disability is actually at a higher risk of sexual abuse than other disabilities. So that one in particular, and again, it comes down to how they can self-protect and those sorts of things, their capacity for self-protection. And those environmental and contextual factors that increase risk, where there is a different caregiving environment, or there's changes. It might be residential, it might be an exhausted primary caregiver, all sorts of things that we look at, that I think a practitioner or somebody working with that person needs to enter with that risk, then look at where their baseline is, and then keep an eye out for shifts in that.
Yes, and then if there's, so coming to you, Victoria, if there's an established you understand that this person is living with some trauma, and just picking up on the point India's made about intellectual disability and that vulnerability of that population, what are you seeing that stands out to you in your clinical work and your day-to-day work with these young people, that you think is very unique to their experience in terms of trauma?
In terms of trauma, sorry, I missed your last.
Yes, in terms of trauma itself.
I think, again, because, with intellectual disability, it can sometimes be a barrier for communication. Not always, but it's also that adaptive functioning part of intellectual disability, which, as India, I think, was saying, that sometimes we get these, there's a big cross section between what disability and trauma behaviors look like. So it's very, very often overlooked in this space, that trauma might be what is presentation rather than the disability itself, because of the lower IQ or the problems with adaptive functioning and reasoning.
And capacity to articulate that or make sense of it. Yeah.
And I think also just that, I think in terms of, working in the sexual violence space, that a lot of people still don't recognise that people with disability actually have sexuality or relationships or even emotions. So for them to be experiencing things like anxiety or, post-traumatic symptoms and things, some people still think that because you have a disability, you can't have these things as well.
I think that links back to that natural bias and assumption that it's the disability that we should engage with, not the person. I think that, Chelsea, I'm going to come to you about what you noticed too about trauma in the populations that you work with, the young people that you work with. What do you know about the unique sort of aspects of trauma that we should be alert to?
Can I make a comment about the previous discussion as well? So I think we also talk about sexual violence in the context of cares to, or an adult to a young person. And I think if we think about some of the settings some of these kids are entering, say respite, they're in a setting of multiple children with a disability or multiple individuals with a disability of varying ages and stages, different sexual kind of preferences and needs. And so I think it's really important to recognize the settings that they're entering increases their risk in terms of other young people being harmed. And so I think what we need to do is actually recognize that that is just as harmful for the young person or for the victim. And it is not something that kind of is accepted within the Resi environment, and it should never be accepted. And I think that's a really important piece. In terms of intellectual disability, that's most of the work that most of the clients that I see have an intellectual disability, mostly comorbid disabilities, comorbid needs. So you'll see a lot of psychosocial disability on top of their intellectual disability. And I would say what's really important, I work with really a lot of high-risk youth and a lot of clients in the forensic setting and justice setting. And we see a lot of individuals who are perpetrating harm against others. And whilst being abused doesn't necessarily lead to becoming a perpetrator, we do know that majority of the population who are causing harm have a history of their own trauma. And I think, again, this speaks to a gap in the actual approach or the treatment that these people have been provided. There's a lot of social isolation. There's a real gap in opportunity for a lot of these people to be explicitly taught skills in terms of relationships and consent in my body and safety, how to have a safe relationship, how to actually manage consent. All those aspects are really, really important. Recognizing the harm that was caused for you, for the young person, and that that's not okay, and working through that trauma and making sure that they don't carry that as an expectation of that's relationships into the future. There's a huge gap, and what happens is this learning history becomes the expectation moving forward. And a lot of what we're doing is not only teaching new skills, but we're essentially reframing old skills and old biases that the person's holding across the lifespan. And a big part of this is actually, particularly with the forensic space, a big part of this is actually starting there and saying, what's happened to you is not okay. And that's a really important piece, but it still doesn't mean you can go on and do this to someone else. So they're kind of two separate things that we have to address. But I think that the lack of opportunity that presents and the lack of explicit education in this space, which is absolutely required. Adaptive modalities to teach is really, really quite critical, and repetitive conversation, I think, is often missed. So for some young people, you can approach a lesson, right? And you can go through the learning curriculum and you chunk information and scaffold and it kind of meets their age and stage of development. So you kind of match it along the board. I think where you have to look at with intellectual disability is how you're having the repetitive messages at all times. What are the core messages that need to be addressed, and how that maintains that consistency across the age and stage as the foundation. So it's how we're teaching is really, really important. It's that responsivity aspect. We know memory is a bit of an issue as well. So not just with that population, but also the aspect of trauma is going to impair their cognitive functioning in that space. So we got to think, it's not a matter of telling them once and that's it. It's actually constant repetition, constant engagement. It's keeping the conversation live, problem solving, consequential thinking. There's so many elements that are really quite critical just by nature of having a disability that we have to work through. And then you add the layer of trauma that's already compromising those deficits that are present. So it just requires a lot of adaptation and patience, just to summarize it.
It sounds like.
Yeah.
India, this kind of approaching all of these things together, can you give us some examples of what that looks like, or an example of what that looks like, you know, for practitioners or parents who might be watching this session? What does it look like to address all of those things, the risk, the trauma, and disability at the same time?
I think it's about having a systems approach. So, and the issue with that is you need to have the system on board in order to do that. I actually think a lot of practitioners already have this, practice framework that values trauma-informed practice, that values intersectionality, that I kind of think that there's so many good practitioners out there. I don't necessarily think it's at the practitioner level. Okay. And Chelsea's right. It's some of it is around training and upskilling the staff in that space. But I think there's those who aren't trained in trauma-informed practice, or those who aren't trained in risk-aware practice, I think are willing. I said, and once they see what the training is or that content, oftentimes you have that aha moment with the practitioners of going, oh, I've already seen this. You've just given me a language to put to it. So I don't feel the practitioner space so much is the problem. I think it's about having a systemic approach that promotes trauma-aware practice and allows the joining of those things. I think it's very much the top-down trickle of
it's the funding of it, right? It's funding it.
It is
and
funding
giving
it. It's funding
yeah,
it and allowing it, because I know that often the pushback I get from practitioners like, yeah, no, we know it's there, but we're not allowed. We can't. Our guidelines say, you know, those kind of things. So I think it's about advocacy to remove the red tape to begin with, and that there's actually an evidence-based reason for removing that red tape, and that other sectors are doing it, and that there's a purpose to this. I think that kind of overarching systemic change is probably vital. And then in terms of the practitioner, the family and the child, it's about awareness raising. It's about, as Chelsea said, ongoing education. It's about ensuring that everybody that is involved in the care team, the stakeholders, are all on the same page, are getting the same information, have the same training, and have the same plan in place, not only to understand risk and assess risk, to understand the young person and what their baseline is versus their where there might be changes, but also have plans in place around if trauma has occurred, how we're going to address that, as you know, as you would any other traumatized young person or traumatized adult, and to have that systemic, consistent message across all of those people that are involved in that young person's life.
And getting everybody. I used to work in mental health, and it was quite a challenge to get everybody on the same page around, you know, approaching and providing consistency and consistent support. There's been a question, Chelsea, I'm going to come back to you around what if a child is not believed, a child or a young person is not believed, and how do we, you know, how do we help a child who's experiencing child sexual abuse but not being believed?
And I don't think this is specific to children with a disability. We know this is a widespread
know
issue.
this
So I'll just kind of preface that. That's the first step is I believe you. If we can walk away today, that's the first step. I think what's two things is if we speak to the communication, I think it's about engaging the right people in terms of how we can actually support this person to communicate if there are communication barriers in the first instance. If we're trying to actually process the disclosure, but really it is about safety. It is ensuring the child is safe in the first instance. So even if there's people who are not essentially recognizing what's happening, or they're not recognizing the risk factors, I think absolutely everyone has a responsibility to ensure the safety. And I would strongly be advocating for that to your integrate. So everything you're doing is essentially just trying to preserve the safety across every context and every setting that this child enters. And that's not just their physical safety, but that is their psychological safety. And so if someone's saying, I don't believe you, or is not essentially promoting their voice, then I would say they're not the person that can speak to that child anymore. I'm a firm believer it is your fundamental right to be able to communicate. So for these children who are not listened to, not heard, or not able to speak it, then that is our first step, is actually providing the opportunity for them to communicate effectively. And then it's essentially same time.
Be believed.
That's right.
Yeah. Can I move to another question that came up earlier, and I flagged it earlier, which was about access to services and services that, so you've talked, Chelsea, about your specialist work, and Victoria has her specialist work as well. But we also think there needs to be, I think, as a kind of coalescing view on the panel, that the generalist services need to be better at this. They all need to be better at working with the child in mind, not just the disability, not just the diagnosis. What about the Australian context where there is challenges to access services in rural, remote settings, the right kind of services that will address this kind of complexity and trauma? What's your thoughts, Victoria, about that? You work in the kind of service delivery space. Are there areas that we could really be advocating for change around that, around access to services?
Well, particularly from my experience working with people with intellectual disability, we and sort of since the pandemic came into existence, we sort of, a lot of practitioners and services, just to keep those services happening, moved into this sort of digital space. That really doesn't work well generally for trauma, I believe, but when you're adding intellectual disability, because all of those factors, like Chelsea said, this work has to be, it needs more time to allow for learning. It needs adaptability. It needs repetition. So, and that in all of that, the biggest part is the relationship and creating a safe space for that young person. It's hard to do that when you're not physically present with someone, and they get to, you know, connect with you in that way. It is such a massive challenge in terms of, you know, what the demographic of the country that we live and work upon, in that rural and regional areas are just not getting access to the type of supports that they need, unless at best it's in the digital space. And if we want to make change across the board, there needs to be some sort of implementation of this into already existing you know, factors. Like most regional towns have schools. Why are we not putting specialist you know, positions, and, you know, not trying to recreate the wheel, we're trying to add to what is already there to make it better for all.
Yeah, thanks, Victoria. Very thoughtful. What do you think, India, about service delivery and, you know, creating, because it feels like this kind of dual track of complex work that takes time, that needs building relationships, that needs repetition, that needs understanding of the context. And so the relationship's really important. And we need to create access. And those two things are hard to do at the same time. What's your thoughts about that as a researcher?
I think it's about being clever in our practice. And I say that as a researcher and a practitioner. The way I would typically address it is to be an informed practitioner. So you can work in the disability space, you can adhere to all of the bureaucratic documentation and still provide a very individualized service. So I would be advocating for that kind of evidence-based practice, which has a trauma-informed lens, that you don't always even need to put on. You know, trauma-informed practice is very much a overarching concept as opposed to a direct intervention. And a lot of things like you know, service agreements and those sorts of things are asking about direct intervention. So, you know, it doesn't really need to be mentioned if it's not relevant to the person you're sharing that information with, but it's about having practitioners who have the skills to be able to have that overarching blanket over their work. So I used to say the same thing when I was talking about child protection more generally, is that it's down to we can't always change the system. That's a much longer conversation, a much longer journey. What we can do is ensure that individual best practice is sound. So having evidence-based, well-informed, well-trained practitioners who have numerous modalities in their toolkit will, I think, enable us to do a better job, at least at that individual level. You know, I took what Chelsea said when we were talking about the importance of being believed. The same vulnerabilities that set a young person up for being at risk of child sexual abuse, the same factors that will potentially set them up for risk of being dismissed, you know, and not having their disclosures heard. So I think ensuring that we have practitioners who are informed about all of these things is something we can control more readily than those systemic changes.
Yeah, I think you're right. And I think, and so that's incumbent on us. There's some messages for us there in the National Centre about how we can start to build the capability of practitioners in that space. Both you, India, and you, Chelsea, have indicated that you're working with in the forensic space and in the context of potentially young people who have harmful behaviours. Chelsea, you spoke about, you know, and they've perhaps got to that space because early experiences haven't been resolved for them, or they've not made sense of them, or they've not had their trauma understood and believed. So can you talk to us a bit, Chelsea, from your point of view about, you know, the interface, working both with those who are presenting a risk to others and but also have their own stories of abuse, and how we might as a community approach those young people?
Yeah, I think a lot of the work I do is within an out-of-home care residential setting. And I think it's a really important context to think about. So these kids are dealing with multiple forms of harm and abuse and grief and loss. And they're sitting in this space where I think if we think about a trauma-informed model, we really need to recognize re-traumatization. And this is a really, really important piece because we're assuming we're just going to be working on understanding their past experiences or essentially treating the current presentation and behavior. But really, we have to think, what is their lived experience in every moment of every day? And how does it actually perpetuate harm? How does it actually impact the lifespan in terms of their mental and social well-being? So I think it's a really important aspect is understanding re-traumatization. This is really important as well within a disability space because there's a lot of form of restricted practices. And in some cases, it involves physical restricted practices. And if we're at an increased risk of sexual harm, and then you have people who are physically removing you by nature of, your presentation, that is absolute invasion of space. that is an absolute breakdown in terms of safety. And that is a form of re-traumatization that's normalized in that setting. So I think what's really important is recognizing first is what are the aspects of this environment that could be re-traumatizing for this young person and resolve those first, because we need to teach the person you are safe and we are here to keep you safe. And then we're going to work through understanding what are those different areas of needs that impact on the presentation. So if we think about somatic work and we think about sensory preferences, we're going to really target that window of tolerance for these people so that their capacity to learn and actually to work towards being safer within their life and towards others, they have to be able to learn. They have to be able to engage in that process. We have to create opportunities where they're motivated and they actually feel capable of engaging in a healthy relationship. And we can't expect that if they're fighting this internal battle and if they're fighting a battle in an environment they just don't feel safe within. So I would say going in and recognizing an environment that is re-traumatizing or has a risk of re-traumatizing. And if we don't target enhancing their capabilities and their motivation, and then creating opportunities for them to actually have healthy, safe lives and actually address their vulnerability, address their mental health in a way that really does promote their capability, that really empowers them in the process. If we don't do that, then essentially we're going to see the risk of counter control, or they're going to project that towards other people and they're going to increase the risk of harm towards others. So I think the out-of-home care setting is a really important one, or the disability space is really important because there is so many aspects of re-traumatization that can hold these young people back, really. I don't know if that answered the question.
No, it does. And it's a really important reminder that the setting and context, we have to attune the setting and context as well, and recognize that we do have some capability in managing that and creating a safe context. So it's not just about the individual. Victoria, you were nodding through that, where Chelsea was talking particularly about the mixed message. I think it's a mixed message of, don't do that, but we're going to control you in a physical way. Did you want to add more to that?
We quite often at Wild get referrals for particularly young people in this education setting that may be sexualized behaviors towards other students. And while that's not the field that we work with, we find that there's such a negative, it's just automatically in the negative, and you start throwing out these perpetrators, and we're talking about 11, 12-year-olds and offenders, and they should go to jail, and it's exactly, and it's a very specialist space, the forensic space, and we're really lucky that we have great referral pathways, because if it's not responded to in that really that lens of what has brought this person to that space, it's not going to address their need and the underlying causes, and then the behaviors, which yes are concerning because they could be harmful to others. But again, it's as we're talking about here, it's looking at the whole of the person and not that particular label or problem that's being brought to them.
I feel like that's the big takeout, to move away from the definition, the behavioural definitions or the diagnostic definitions, and move behind those and really think about the person and understand the person in that context. I think, yeah, please go, Chelsea.
I was just adding to that. I think what's often missed as well is we're managing risk once we actually see something happen. And I would say the big thing in a forensic context is proactive risk management. And I think this speaks to prevention as well. When we think about young people, proactive risk management is prevention. That effectively is education prevention. Within a forensic context, we're seeing harmful behaviors that have a significant impact on others, and we can't privilege one person's rights over another. We absolutely need to protect all victims in this situation, including the person. And so I think it's about really understanding what is our role here. And I think a real important message that I always, I'm just the risk queen. I absolutely talk about risk in all aspects. So I'm loving India's discussion. But this is it. It's about recognizing all these risk factors, all these cues, these behavioral symptoms, the early indicators of changes in someone's behavior, and intervene. It's all proactive risk management. That's not a scary thing. And that's essentially avoiding us getting to the point where we are re-traumatizing someone by nature of really extreme responses. It's essentially teaching them, but managing safety of all people really, really early. And I think that's probably a gap in people's knowledge base, is that real proactive, open, transparent risk management approaches.
Yeah, thank you. Fantastic. Thank you.
Can I jump in there too?
Please.
Because I was thinking about what both Chelsea and Victoria have said, and it's this understanding of motivation. You know, if we're looking at, and the idea of an out-of-home care environment is perfect, because you also have what most people consider to be a criminogenic environment for any young person. So the idea that it increases the likelihood that a young person might head down the pathway of criminal behaviour or delinquent behaviour in the first instance from a crim perspective. And so, but it's about, again, getting behind that and going, okay, well, what's motivating that behaviour? Why is this environment, increasing that risk? What trauma or experience has occurred? What developmental delays do we have? What traits, characteristics, and risk factors do we have that might be influencing that kind of behavior? We know that with young people, especially in the out-of-home care environment, that it comes down to things like attachment and belonging. They will often join, and we're talking about developmental ages where they're usually heading down that path where peers become really important and dominant. So we already have some developmental elements that are naturally placing a young person at risk of heading towards groups. If they pick the wrong group, again, it's the same vulnerabilities that a young person would have for sexual risk or any kind of abuse risk, where you have those kind of cognitive vulnerabilities or decision-making vulnerabilities, relational vulnerabilities that could predispose them to making poor choices in that sense as well. So again, it comes back to understanding those traits, factors, and vulnerabilities that expose that young person, and then understanding the motivation for offending behavior, especially when we're looking at sexualized behaviors, where we have that spectrum of experimental sexualized and then harmful sexualized behavior. You're not going to get out in front of preventing that young person from going and causing harm if you haven't got to the root of what's happening for that young person to cause that in the first place, and do all of that repetitive work to try and undo. If we're just treating the symptom of the trauma, which is all that behavior actually is, then you're never going to get anywhere in terms of, again, those outcomes. So that would be my takeaway too.
I think this has been such a rich conversation, and I just note that we have focused quite a lot on children and young people, and absolutely that's the right thing for the group that's gathered today. It's the work that you do and the expertise you have. I would also like to acknowledge that there are other sorts of disabilities, and there is also lifelong impact. So we know that at the National Centre, we're thinking about the lifelong impact across adulthood of carrying complex trauma from childhood, and the struggle in finding services that understand that and can work with that. So, just acknowledging and recognising that. We are coming very fast to the end of our time, and we're not there yet, but I would like to ask each of the panelists today to just talk about what they most want participants to take away with them from this conversation. So we've had 60 people with us, and that's fantastic. They are still with us, and we would be, and I think we've had a mix of people, as we usually do, from a practitioner out-of-home care context and people who live with their own experience of child sexual abuse. what would you most like that the audience to take away today from this conversation? And I will start with you, Victoria, if that's okay.
I think, I mean, I don't know who the audience are, and I might be speaking to people who already have this. And this, I guess my take would be for the biggest system is that for anybody that is working with young people or adults with disability, is to recognise that trauma and abuse, including high numbers of sexual abuse, is likely, and that trauma assumed. I love that saying, by the way. Trauma assumed lens is so important for any work that you're doing, regardless if it's in the practitioner space or the caring space, education space, and that while it's important to understand that the disability for the person, because you need to know that to create that big picture and those baselines and things like that, but to look past all of these labels and diagnoses, and look at the whole of person, because that's otherwise we're pulling them into different sections, and we're not going to get a good outcome for them in terms of that whole of like India, I think it was forget me, it was the trauma and the disability and the life and the
Yes.
I'm not sure I could repeat them now.
Yes.
But
all of those
wonderful,
narratives.
so I hope somebody got it.
We do, and people might know who are generally attendees of these webinars, that the team takes the gold from the panel and turns it into resources that you can then access. So I'm sure they've got that, India. It's all recorded, and we'll have it written down. Victoria, thank you, and thank you for. Were there other things you wanted to add before I move?
Just in terms of if there are practitioners out there who are already working with children and young people, but not specifically with children with disability, is don't be afraid of that, because it's just an additional part that you need to consider in the whole of person. And you've probably got great skill sets that you would use, and it's just sometimes about finding ways to adapt, as you would with any young person that comes through the door, to their learning style or their concentration length, or so really I encourage people to, if you feel a little bit like that's not your expertise, it's just you've already got the skills there, and just adding those extra things of repetition, perhaps more time, shorter sessions, give it a go.
Beautiful. Thank you for the encouragement. Chelsea, what would you like to kind of round us out with?
I think education is absolutely our biggest asset. And I think every person has the right to be able to learn all these foundational skills that are going to keep themselves safe and that protects their rights and promotes their rights. And I would say that's probably the takeaway is it can almost be scary to enter this space and say, oh, I don't want to cause more harm. I don't know what to do. I'm not the right person. I think even just an hour ago, I was still saying I'm not the right person to be on the panel. Right? I'll speak because I have so much respect, and I just want to protect this space because this is such a vulnerable group of people. So I would say for practitioners, particularly behavior support or in the NDI space, support workers, carers, step one, teach protective behaviors, talk about rights, talk about your body at all ages and stages. A lot of our young people or people with a disability have learning histories that are really complex. They have learning history that have forms of abuse or maltreatment or neglect or social isolation where they haven't actually been taught specific skills that allow them to have a healthy relationship or allow them to experience things that a neurotypical individual might experience just by nature of their socialization. And so we need to think about that. We need to think about the gaps in their opportunities that they have in life. Entering a respite facility with other young people with a disability is not a typical environment. We are moving towards much more inclusion, which is really a positive shift in society in general. And we see that within education, and we see it within society. And that's a really positive shift across the community. But that means everyone has a role to play now, not just specialist environments. Everyone has a role to play in advocating. And I would say step one is teach these people about their rights, teach these young people, teach adults about their rights to protect themselves. about other people's rights, about consent, about your body, about body awareness, about safe people. I always do with all of the young people I work with, I always do circle of support. And we don't just recognize who's in their circle. We absolutely talk through what makes a safe person to enter your circle. And then you can choose that person to go in and out, because that might happen. And so it's about them recognizing those signs and behaviors of others that essentially they're allowing in their space. It's empowering them to recognize, I'm going to put you in my circle of support, and then I might take you out, and then we're going to repair and we're going to work through it. Right. But it's empowering their voice through skill development. So I just don't want to underestimate the aspect of when you're working in this space, promoting and empowering their voice is actually through skill development. So start there, and then you're on the front foot, but always start there.
And I think you also said, which I'll go away with, this idea of just believing is empowering them.
100%.
Believing is an act of empowerment.
Can I say one more thing as well? Is in disability, I have a lot of, I actually had a practitioner call me the other day, and she said, oh, I think I've said the wrong thing to this young person. Can you just let me know? And this young person was, without explicitly saying, this is what's happened to me. She was essentially alluding to, are you going to let me down? Is everyone going to let me down? Are you going to stick around? Or are you just going to let me down like everyone else? And this young person has a significant history of harm and trauma. And some of the staff were quite concerned about saying, yes, we're going to be here for you. We're not going to let you down. We're not going to go anywhere. And they're saying, oh, that's a really high expectation given the turnover in the sector. And I know where they were coming from. I truly understand where they're coming from. But I said, I would actually turn to her and just say, what's happened to you is not your fault. Because that's the point of the story. It's not, are they going to stay or go? It's people have left you and that's not okay. And they've hurt you and that's not okay. And it's not your fault. That is absolutely not your fault. What's happened to you? And now moving forward, this is what we're going to do. If there is a change, I'm going to talk to you about it. I'm going to involve you. But it's not about, did I say the right thing? Did I respond in the right way? It's actually going back to, fundamentally, it's not your fault what you've been through. And it's just that, it's just starting from that really humanistic, protective point of view. I think we can get lost in the dialogue without actually focusing on that first. It's just protecting their well-being first.
Yeah. Chelsea, thank you. Really amazing wisdom. India, you've heard the other takeout messages. What would you like us to go away with? And now we can't hear you now. I'm not sure what's going on there.
Can you hear me still?
We can hear you now.
Apparently there's extra little buttons on these things, honestly. Yeah, it's all, there's always a problem child in these presentations, isn't there? I might as well be that. Hard act to follow, but look, I guess my takeaways are particularly around the lifespan implications. I know you mentioned that we've spoken a lot today around the impact on children and how to manage children in that space. But I feel like we also need to acknowledge that there are lifespan implications. So even though we've looked at childhood, that's because the way that we respond to these things, acknowledge the way we understand risk and trauma and disability in childhood, has these incredible ramifications right across the lifespan. Tapping into what we talked about around, different environments that young people end up in terms of the potential for perpetration of different harmful behaviours because of their experiences, that's potentially then also going to set them up for further disadvantage and further re-traumatization, further re-victimization. We know that victimization in childhood has huge links to re-victimization over the lifespan. So I think it's one takeaway is to take a lifespan approach to the work that we do in this space and understand that it's across a continuum, that it is cumulative. I can't believe I've made it through an entire presentation without using that word, because that is my buzzword. I had to get it in at the end, but that it accumulates over time and increases so that you end up with a condition of victimization and a condition of victimization and disadvantage rather than isolated events. You've got to look at them all together and how they layer. And then understanding that the risk, harm and disability, of course, always co-occur and can need to be addressed together, and that disability increases impacts, disability increases risk, trauma increases disability, and the way those pieces all work together is definitely my takeaway today around the way things are reciprocal in this space, that it's cyclical and reciprocal. And that if we don't focus on the way those things all speak to each other, that we can't effectively intervene to support safety and change.
Thank you. And look, amazing way to round out the conversation. I hope we've picked up the main themes from the questions and comments in the chat. And I hope that people feel like they've had some of their own queries addressed through that conversation, which I think was remarkable. Thank you for engaging with it. Without a script, and you bringing your expertise to the table, and obvious, long and wise experience of working with people with disability and in this trauma space. Thank you too to Tanya and Kerry for their interpreting work, and thank you for your time with us. Can I encourage people, if you have found this traumatic or concerning, that you follow up and look after yourself in the way that we suggested earlier on, and just recognise that there's people to talk to, and because this is difficult. And one of you right at the beginning said this is really confronting, to think about how an adult might abuse a child who has a disability. Let alone a child, but also one that has a disability. And this is a real confronting conversation to have. So just recognising that, and drawing back to Victoria, Chelsea and India, and thanking you so much for bringing your expertise to the table and working with the National Centre on this. We do these webinars once a month. Our next one's on May the 2nd, and you will find out more about that session as we land the speakers and share that with you. We will also send you a survey after this to find out what you thought of the panel, and particularly keen to hear what you think we could be doing better, differently, and in a more responsive way, so that we can continue to make these sessions very accessible. Thank you again, everyone, for your time. We're going to finish the webinar now, and look forward to seeing people come back for next month's webinar. Thanks, folks. We'll finish the session.